So it's my pleasure now to welcome Andy. You already met him, and yeah, maybe you can also take. Yeah, sure, over here. And he introduced himself, representing Sarcoma UK, and he will tell us now about the topic unique among cancers. What makes sarcomas different and why it matters. So we know that there are a lot of different cancers around, common cancers, but also rare cancers. And we have briefly discussed that rare cancers are around about 24% of all cancers. This is a huge number with the rare cancers. And now we are ready to get the talk from Andy. Thank you, Andy. Cool. Just.
All right, okay. Where do I put this? Good afternoon, everybody. Lovely to be here, and it's kind of been a wonderful conference, my first one attending. So I've already obviously introduced myself. I'm going to talk to you about this report that we've done, which was a major piece of evidence gathering. I work for Sarcoma UK. We work across the whole of the UK. I oversee the charity's policy evidence and work influencing government and the National Health Service. Please excuse me if I cough through the kind of presentation from last time. I've recently had a bout of asthma, which is not quite kind of settled. So first of all, I'm going to kind of the things that I'm going to kind of cover in the kind of talk, give a bit of background in terms of the UK, why we did this review, our aims and our scope, what we did, what people have then told us, why we feel sarcoma is different, and why that matters, and then looking at some next steps with a positive. So in terms of the kind of why it's different, I mean, there's essential points. I'm not a clinician has been more than kind of established. I haven't been a kind of trainee doctor just now. But the kind of key things about how the condition presents, its rarity, how different it is across all the different subtypes, difficult to diagnose, to treat, complex to manage. But also, there's all these other barriers that kind of get in the way in terms of how policy and the health system doesn't respond well enough to people with sarcoma. But obviously it should do, because we all matter and we all deserve the best chance, and especially if you're diagnosed with sarcoma, we all deserve the fairest chance possible. Our vision as a charity is we want everyone affected by sarcoma to live longer, better lives, and that no one should face sarcoma alone. So in terms of the UK's context, for the benefit of people in the audience not from the UK, there's about 5,900 sarcoma diagnoses a year, 700 bone, about 5,200 soft tissue. Social deprivation has a major part to play in that, and there's some work that was kind of recently commissioned from a number of years ago. University College London looked at kind of 84 soft tissue sarcoma subtypes from patients between 2013 to 17. Net survival was about 85.8% at 1 year, about 70% at 5 years. Cases are more commonly reported in affluent areas. We believe this is really possibly to do with kind of people being picked up earlier in that case. But there's about 22% of cases versus 16% in most deprived quintile. So in other words, if you split down areas across the UK in terms of deprivation, the wealthiest to the poorest, that's what we're talking about here. Soft tissue sarcoma patients living in the most deprived fifth of areas, they're 22% more likely to die within 5 years versus people in the more affluent areas. And there's also an increasing likelihood for patients to present through emergency route as deprivation increases. So there's clear evidence here about health inequalities. So these are basically the differences in health across the population and between different groups in society that are systemic, unfair and avoidable. So these aren't things that are right and fair and just, but they also don't have to stay as they are. So the other kind of key things here, in the UK we have a National Health Service which is free at the point of use. In Northern Ireland it's health and social care. Rationing happens to some extent, but you have 4 different governments. They all set policy slightly differently. They all oversee their health service in slightly different ways. So sarcoma is rare, as we've mentioned. since the early 2000s, you've got kind of specialist centres under a multidisciplinary team model. And the key thing that we want to obviously make sure is that everybody gets to a specialist centre. You get the right diagnosis, you start the right treatment. There's 5 bone centres in the UK, 17 soft tissue centres in total. Key thing here is that local commissioning is kind of distinct from this national commissioning. So there's often a kind of a disjunction or a kind of disconnect between the two. Also, the other thing is, in terms of the maps that I've shown there, basically people will travel a very long way to get to one of these centres. So again, it's cutting across the kind of administrative and political boundaries. So in Wales, you might well end up going to Birmingham, which is in the middle of England. Similarly, from North Wales, you go to England as well. And you can see that this is kind of covering a vast swathe of the country. In terms of why we did the review, so we felt that kind of basically, although many people have been getting really good care, there's far too many people we've been hearing from, including for our support line, which provides emotional support and advice and advocacy for where you should be in the health system, that people don't get the best experience. And we're concerned that sarcoma is falling behind other cancers. So we felt we needed to look across the board at what's happening and what needs to change. So we've done some really good evidence gathering in the past, kind of back in 2020, and our national sarcoma surveys, but basically our evidence was getting out of date. And we also know that there's kind of the data within the health system is poor. There's not enough research being done to understand the condition. And we basically had been trying to address some of those issues ourselves. So we've been doing work around data with the Bone Cancer Research Trust to make sure that we get a better analysis about these health inequalities and the inequalities within the system. We'd also been doing lots of work around kind of funding research ourselves, cutting-edge world-class research. And as a proportion of what goes on in the UK, most of it is actually done by the charity sector, especially a big funder like Cancer Research UK. But in terms of incidence, only about half of what should actually be funded in terms of just the incidence, in terms of proportion of funding, is actually being provided by the biggest funder. So we've tried to step into some of that gap. Other areas, things that we've been doing, we work with a kind of group of clinicians, Sarcoma Advisory Group chairs, so these are basically the lead clinicians across the UK who run specialist centres, discuss best practice, frontline delivery issues. We've also done a lot of work around early diagnosis. We have an early diagnosis steering group. So they've helped with some of these kind of really great training kind of products that we've done for the health people in the health service. There's one for GPs, one for physios, for trainee doctors. We've done a kind of lumps and bumps kind of tool for people to measure the size of the lump and is it changing. Also our Sarcoma Awareness Month campaign, which we do every July. This is one from a couple of years ago. A member of my team came up with this idea, get everybody to hold up a sign saying how long did it take you to get a diagnosis. Some of the people you can see on there, and this is basically we did on social media, we did billboards. Some of the people on there, you know, there's a person there kind of 14 days, somebody 1,300 days, which is in the context where people are supposed to be getting the diagnosis within 28 days in England and 62 days within the UK as a whole in terms of starting treatment. That's obviously unacceptable. So, so there's some really good work we've been doing, but I just thought I'd show this slide. This is some of the research that we spotted.
Just for clarification, sorry interrupting you.
Yeah, of course.
What was the starting point for counting the days?
From where the person went to the GP.
Okay.
So not when they, not
their personal symptoms, as I pointed out, is a difficult issue, but when they first see a doctor.
So they may have had the symptoms for ages, but they finally decided to go, and so that was what people were telling us there. So some work we funded, and this was by one of the hospitals in Birmingham in the West Midlands in England. They did some analysis, and what they kind of found fundamentally is that the main delays from the presentation to referral, which is the dark blue line. So the pathway essentially isn't working. People aren't getting through soon enough. So obviously the pale blue is basically the person feeling unwell, finally going to the doctor. The white bit is basically when you actually get referred to the MDT, the multidisciplinary team. And what we found also, people are kind of getting referred on quicker, the higher stage of or grade of the cancer. So again, within the kind of cancer waiting times in England, which is kind of set down by the kind of different governments, this is kind of clearly unacceptable, but this is kind of showing some of the systemic problems. So in terms of the review, we've kind of got a picture of things aren't good enough. We needed to take a more strategic approach. We were trying to deal with things quite a piecemeal way. We're a relatively small charity. Anyway, so we decided to do what my chief executive described as a state of the nation review. Look across the board at everything, get an up-to-date picture of sarcoma care across the board. Let's look for best practice, what needs to improve. Look at the whole pathway. This is to be qualitative, though, around people's actual experience in terms of what are they going through, what's really happening. And in terms of how we did this, it was kind of fundamental that we kind of brought in people's lived experience. We set up an advisory group, 50-50, about 24 people, I believe it was, 50 patients, 50 healthcare professionals. That meant it was kind of democratic and balanced. We also had the chair of the British Sarcoma Group, or the president of the British Sarcoma Group, who's kind of a surgeon in Birmingham, one of the top centres in the country. We had a couple of consultants we kind of recruited, and one of the people on that kind of guy called Andrew Liddell. We appointed the consultancy through open recruitment. People had to apply. Andrew was a former journalist. He was a former special advisor in government. He'd also been a chondrosarcoma patient. So essentially, we had this group of people who obviously with lived experience, kind of fundamental to the project. We had a consultant helping us really drive it forward who understood the issue personally. And we basically looked for where policy and NHS was doing well, good practice, where it needs to improve and how. And then eventually we launched it in June 2025, and we did lots of launch events in the parliaments and so on. We got a really good response from kind of people with lived experience within the healthcare community, also from most of the governments, researchers and charities and so on. And it was really, really spread across the UK. We were really pleased about that. We also did this kind of particular project, the National Sarcoma Survey. We do this every 5 years. And this is basically a quantitative study. So it fed into us our overall kind of state of the nation review. And we basically pulled out key stats. It confirmed lots of the messaging that people were telling us. And in terms of what people told us, the key message was that once you get to a specialist sarcoma centre, people feel really looked after. They felt like they were in the right place. They felt really relieved. They felt like the care was really good. But we found lots of inequities, lots of kind of issues. There's kind of 9 areas which we covered. I'm going to mainly kind of feature on, kind of pick up on the kind of the ones I've put in there in pale blue or pale green, however you see it. And in terms of how we put the report together, which was important, we basically wanted the report to be used in influencing, to try and make the case to government and the health system, to draw it all in together to one big product. So that, whatever your level of expertise, as a layperson, you could find everything in that one place, understand it. So what's sarcoma? Who is it affects responsibilities? Who's doing what in the system in terms of government and policy and saying this needs to be set up and this is how it's delivered. We set out also to show what official health policy says is supposed to be happening and government saying it's supposed to be happening, like the cancer waiting times, what's happening in terms of diagnosis or access to mental health support. That being the context. And then actually, against that, we could put people's experiences, their qualitative evidence, and tell us, actually, again, this is what's supposed to be happening, this is what's happening to me. And that being a picture overall. So, running through some of those areas, delayed diagnosis. So there's lots and lots of feedback we hear. This is obviously a summary in each of these following slides, but patients seeing their GP loads and loads of times, having to keep going back, vague symptoms, which has been hearing this morning in this previous session. Basically, lack of access to imaging for some GPs, this being kind of key. Our National Sarcoma Survey, 1 in 3 patients visiting their GP 3 or more times. If you're female, it's like you're more likely to have to go back and back again and again. Many sarcoma patients have a long kind of route to diagnosis, one GP told us, and nobody's listening to them. Many people have delays in their initial diagnosis, and basically there's a problem there in terms of GPs and no MRI or ultrasounds. Also, some really concerns from healthcare professionals about a clinical nurse specialist, a CNS. So they're really, really angry about the fact that they're seeing lots of 30-something-year-olds, and they basically keep going round and round the system, and eventually they get a diagnosis. But obviously, it's a real person with a real life. On pathways, lots of people kind of told us they did get through, but actually a lot of people didn't. You know, the delay in terms of the pathway was kind of fundamental in terms of people getting the right diagnosis and in good time. And especially there was a particular discrepancy here in terms of gender, so especially women basically being discriminated against within the system. 1 in 5 patients initially treated for a wrong condition according to our National Sarcoma Survey. So put on, you know, misdiagnosis, put on the wrong treatment. Women and young people, especially, that happening too. So again, some of the quotes: not referred to the specialist sarcoma centre, don't know why, not given any information, very satisfied with the treatment, the follow-up's been absolutely wonderful, another person saying. And then, you know, some of the other feedback we had from oncologists: why does it all have to be so different? So there isn't a standardised way of arranging things. I know, obviously, Britain isn't the biggest country in the world, but you would have thought there would be the capacity to get some kind of degree of standardisation in a well-developed country with you know, some degree of kind of good public funding in this area. Workforce, this is kind of fundamental to any kind of healthcare system. So the feedback we have, that people felt really positive about the NHS staff that they came across. But the healthcare professionals were telling us that there were key shortages, clinical nurse specialists, pathologists especially. Actually getting into this particular part of the profession was kind of quite difficult though, you know, in terms of training, and people kind of finding that really difficult. Histopathology, again, in terms of the quotes, an issue. Issues in terms of the oncology workforce in terms of sarcoma, Northern Ireland, clinical nurse specialists, there's just a couple, and there's kind of reliance on the charity sector. The training issue here is pulled out by one of the surgeons about it's not a core part of the training for people. Research, so lots of concern. Obviously we've heard this morning about kind of in Robin Jones's talk about the importance of trials. Patients want to get access to them, but there's a lack of information and access. There's kind of barriers to running trials in the UK, lack of incentives, bureaucracy and funding issues. Lots of different kind of problems in terms of regional inequalities. Lots of people have to go to the southeast of England to get to them. We had one person give us some feedback in terms of their evidence. They were in Scotland between Edinburgh and Glasgow. They had to do a kind of trains, planes, automobiles thing to actually get on a trial and travel back the same day, and it was back a 12-hour round trip. Our National Sarcoma Survey, this is one of the, we had some good results in it, but this one area of particular concern, that there was basically a fall in the number of adults kind of have been told that they'd actually been given access to a trial down from 21% in 2020 to 10% last year. Also, lots of people kind of a concern around having to find things out to themselves. This is what a female patient told us. And basically, you know, having to do lots and lots of pushing to do that. Also, from an oncologist, is basically the kind of the fundamental thing around the kind of the market system, and it not being kind of, what was it, basically the profit-based kind of basis to, obviously, kind of in terms of the pharmaceutical industry, and sarcoma being relatively small, in not being, you know, attractive financially. Mental health. So the significant emotional mental kind of burden from sarcoma, particularly unique combination of stresses we've felt: rarity, isolation, high likelihood of appearance and function change surgery, broad age range, especially also affecting a younger age range of people. The other thing was that people told us there was a lack of mental health support. This was the number one thing that kind of comes up in our National Sarcoma Survey. People persistently say they need help with their emotional well-being, but the support isn't there. Also, the impact being felt by carers. So this is a kind of particular kind of key concern in terms which came out of the report. And this is kind of a real area of kind of need, and kind of where more progress needs to be made. Data. In terms of the health system, we have 4 systems, but we have lots and lots of inconsistent data collection. There's a reliance often on individual healthcare professionals deciding how to collect data. And there's a reference there to one of the quotes. It's pathetic, really. We have to do our own database. That particular team's use an Excel spreadsheet. It doesn't really keep much data, but that's as far as they actually have. There's no funding for it. There's lots of kind of challenges around collecting the data in terms of coding and so on. And basically this is important though, because obviously you misallocate resources. You can't really measure how things kind of are kind of how good or bad they are. In terms of the official statistics for England, only about half the sarcomas in the 2024 across the whole of the year were actually recorded and staged properly. And then just touching on things to do with accessibility and aftercare and palliative end-of-life care. So lots of long travel times for people to travel to these specialist centres, financial costs and impact, especially if you've got children. The NHS itself is quite a cumbersome, difficult organisation to navigate. If English is your first language and you're educated, if you're not, it can be extremely difficult at the best of times. Most patients were able to get access to aftercare, but it was very kind of patchy. Again, palliative care, there was like lots of lack of integration. And that being kind of really important because basically people felt like they were left alone. So in terms of why we felt sarcoma was unique, apart from the fact we kind of workshopped the title.
You need to come.
Sorry?
You need to close.
Okay. Okay. So we felt it's basically it's the health system. I mean, essentially, it's a rare condition, lots of difficulties, but then you've got all these other barriers in the way. So we put the report together, made lots of recommendations. Also, we had kind of case studies from people and some really good practice which we pulled out, which actually is happening. A couple of really good pieces of news. So we called for an optimal pathway. As a charity, we were approached by the government to actually start working on one, and we're actually doing that now. So we hope that will go live next year if we can get it kind of concluded. We called for a review around kind of research. There was an MP in the UK Parliament who pushed through something called the Rare Cancers Bill. That's now been taken forward by the government. It's part of their official plan to expand trial access, get better join up, more equitable access. It's now going to be a kind of real kind of focus for the government's work in the area. There's lots of other kind of positive kind of initiatives within the government's plan. So these are some really, really positive steps that we're celebrating at the moment, and the rare cancer charity sector is. Anyway, there's a quick run through at the end, but that's about it really, I think. So thank you ever so much for listening, and if you have any questions, I'd be glad to answer them.
Thank you very much, Andy. Unfortunately, we don't have time to answer questions directly, but I'm sure that you are able and willing to send the report to everyone by PDF, by email, so who's interested into the report. We can also distribute the report via SPAGN. So I think it's a fantastic piece of work. Thank you very much. And also, please give our regards back to Richard and all your colleagues. This is really fantastic. So thank you very much.